Hello everyone, let's try to solve this question together. A catheterized urine specimen on a 24-day-old infant is obtained and that is reported to be positive for E. coli. The sensitivity and ID is presented below. The infant is treated with IV cefepime for 7 days. The infant is noted to have grade 2 and 3 hydronephrosis in right and left kidney respectively. The best way to prevent further UTI is, pause the slide, take a look. What do you guys think is the correct choice? Okay, the correct choice here is start oral amoxicillin. So why are the other options wrong? Oral Bactrim is a good option because you see is sensitive, but the thing is baby is already 24-day-old and we don't use any Bactrim in first 2 months of life because of potential hyperbilirubinemia and kernicterus. So that's why Bactrim is out. One can switch to Bactrim after 4 months. So why not VCUG in first week? VCUG, is after first infection. This baby has only first infection, is not indicated because of many risk of radiation and other stuff, and the yield is not that much with VCUG and neonate. So one can wait on that, and follow clinically is not the right choice because this baby needs treatment. The other tricky part with this amoxicillin is, if you guys can see that this bug is resistant to ampicillin. So one can think that why we are using amoxicillin. So basic idea is that this prophylaxis is general prophylaxis for all the bugs, not specifically for this bug. So that's why it's needed. The other thing we have to consider whenever we put somebody on continuous antibiotic prophylaxis is, of course, resurgence of resistance. That's a common problem. But again, studies have shown that the benefits outweigh the risk of resurgence of resistance. So and there are criteria which I'm going to talk about. So again, once you are placed in this position where the infant has grade 3 hydronephrosis, always put on some prophylaxis, and especially the patient who already has a documented UTI. Let me just walk you through a few references to complete the presentation. So this is a nice reference. You guys can pull it on the internet. It's freely accessible. And here they talk about, so easy to remember, if the hydronephrosis is 1 or 2, no need for continuous prophylaxis. And of course, if there is no hydronephrosis postnatally, they are talking about fetal dilatation noted and then postnatal follow-up. So postnatal is really, you can do an ultrasound in 4 to 6 weeks if there was no hydronephrosis, and then follow. If you noticed that the hydronephrosis is grade 1 to 2, or the anterior posterior pelvic diameter is between 7 to 10, there is no need for prophylaxis. So that's the important part on this side. This side, I don't want to go into detail. You can pause the slide and look. So the case we presented, interestingly, have 1 grade 3 and 1 grade 2. So that's why in this case the prophylaxis was indicated. So that's why you see here that prophylaxis is, you can question, but it should be given. And VCUG here they say plus minus, but like I said, we don't do it because of the risk associated and poor yield. So this is the article which I was referring. You guys can pull it, and there it shows that the routine VCUG really has poor yield, and like I said, exposure to radiation as well. So we should avoid that. And also American Academy does not recommend routine VCUG even in bigger infants from 2 to 24 months. The other one is this article. You guys can look at this. The other one is this one, which talk about how to take care of hydronephrosis and VCUG. This is a nice article too, which described this is specific to vesicoureteral reflux. And this is another article that talk about how to treat children, but that is not really pertinent to neonates, but I put it there just for the completion of the reference list. I hope you guys have learned something together today. You guys have a wonderful day. Bye.